Great. So I'm excited to introduce today's session titled Putting the Aid Back in Medicaid, the link between SDOH and quality, brought to you by Centauri Health Solutions. Centauri Health Solutions has been a longtime supporter and partner of both MHPA and our member plans. I want to thank them for pulling together and organizing today's webinar. With that, I will turn things over to Don Carter, Centauri's Director of Product Strategy, for today's presentation.
Afternoon, everyone, and thank you so much for joining us today. And thank you, Eric and MHPA, for having us. We are excited to bring you some great content today about putting the aid back in Medicaid and how we do that. So without further ado, we'll move right into the content since I have a lot of great content for a wide variety of different folks in the audience. All right. So we'll start with, an introduction about me, your presenter, and you can read about me here and what qualifies me to talk about this particular subject. But what you won't see here is that I am also a member of a rural community where 5 miles down the road, there are still people who do not have working indoor plumbing or electricity. Many do not have reliable transportation sources, and they live at least 30 minutes from the nearest grocery store. And you're going to see in the upcoming slides why I'm mentioning this and why it's relevant. Many also have the poorest health outcomes in the state in this particular area. And this is despite most of them being enrolled in government health insurance programs such as Medicaid. And so over the course of the next hour, we'll be talking about how we can collectively make a difference through the work that we do every day. And so now let's move into our learning objectives. And we have a few here. First, we're going to define and understand some key terms because we may have some folks who are kind of new to this subject. And I want to be sure that everybody understands the terms we're using and how they are similar but different because they are often used interchangeably. We're going to review the various policy levers that state Medicaid programs can apply to address social determinants of health and associated health-related social needs, which is what that acronym stands for. So this is just kind of a review of what exists from a policy level to allow Medicaid and health plans to address needs that are specific to the populations in their states. We will discuss how health equity and social determinants of health are tied to payment and quality measurement and how this is evolving. And then we'll spend quite a bit of time understanding how comprehensive payer and provider collaboration is critical to the success of health equity strategies. And we'll explore how to leverage data to gauge the social needs index of a population that effectively informs focused retrospective and prospective strategies for care management and quality. So a lot of content for you today, and I wanted to kick it off with an informal polling question. So we don't have the interactive feature on because we kind of want this just to be an introspective moment. And so our first question here is, can you name all 5 aims of healthcare's quintuple aim? And we have choices of yes, no, don't you mean the triple aim, or did we just blow right on by the quadruple aim? And so hopefully your answer to this question is yes, but it may have been tempting to answer D. So let's talk more about this in the next slide, what we mean with this quintuple aim. Now, the quintuple aim is a framework for healthcare delivery that aims to improve the quality and accessibility of care, and it has evolved since its inception in 2007 as the triple aim. Provider satisfaction was added in 2014, and the advancement of health equity was added in 2021. Now, it has often been said that the reason for adding health equity as the 5th aim is because healthcare quality improvement without it is a hollow victory. What I also want to point out, besides these two large, I'm sorry, you'll understand why this is in the upcoming discussion. So I want to make sure that you understand what all these things we're talking about, of course, costs in terms of dollars and cents, which are highlighted in red here for your viewing pleasure. We've got some big numbers here. So what I want to point out, besides these two large red numbers, is that this is about achieving one's health potential and that the path to accessing care looks different for everyone. This is largely due to social determinants of health and other health disparities, which is why we need to pay attention to them. So here we see, some pretty big numbers that these determinants account for approximately $320 billion in annual healthcare spending today. And if unaddressed, this figure could grow to 1 trillion or more by the year 2040. And this mandates, of course, that we pay attention to this. So I just wanted to point out that we're talking some pretty big numbers here, and you'll see some more in upcoming slides. So here we've got some key terms, and I know this slide's a little bit hard to see, but as our first learning objective, I wanted to illustrate that you will often hear a variety of terms related to health equity and social determinants of health. So I wanted to include this graphic that illustrates their meanings. These terms you will often hear discussed interchangeably, but they are actually different. And missing from this graphic is the term health-related social needs, which I used earlier, but it too, has another the meaning of social determinants of health. So those two you will see used interchangeably. So now let's take another moment for a polling question and consider what percentage of healthcare outcomes are said to be attributable to social determinants of health and not organic causes of illness. And we've got some options here as 80 to 90%, 70 to 80%, 50% or greater. It depends upon whom you ask, and they do not affect healthcare outcomes. So hopefully you answered correctly, and the answer is A and D. Most sources state that 80 to 90% of healthcare outcomes are socially determined, but other sources are a bit more conservative in their estimates. So it depends upon whom you ask and what source you're looking at. But in any event, it's a lot. So what are these social determinants of health? And again, recognizing the fact that we have probably a wide variety of folks in the audience, I wanted to be sure that we define what these are. Now, I'm going to use the term social determinants of health because it's likely the term that folks in the audience are the most familiar with, and health equity strategies focus on these, so we're going to start there. Now, as we've said, these have been estimated to be responsible for 80 to 90% of health outcomes, and they are not usually addressed as part of a standard biomedical health assessment, which is important. So in other words, we don't have a lot of patients, members, et cetera, talking with providers about these. So as a result, traditional medical care addresses only 10 to 20% of the controllable factors that make a population healthy. Not only that, but according to a recent report, 68% of patients have an SDOH, primarily financial insecurity and isolation, and 60% of these say they have never discussed this with a healthcare provider. These determinants affect everyone, and no one is immune to their effects, as you will soon see. Now, if you do a quick Google search of this term, social determinants of health, you'll get about 245 million-ish hits. So it's clearly top of mind for many. And also in the Google, you'll even see that depending upon whom you ask, there can be anywhere from 5 to 12 SDOH. But these 5 are the ones that are generally agreed upon. And these come from Healthy People 2030. All right, so let's talk a little bit more about dollars and cents in terms of loneliness and food insecurity. So as we move into our third learning objective and start to look at the association of these determinants with healthcare quality and outcomes, let's once again have a look at the impact of these determinants from a cost and quality perspective, especially since our quintuple aim is concerned with costs. As you see here, there are costs attributable to heart disease, stroke, diabetes, hypertension, a number of very costly chronic illnesses, and with a variety of quality measures that are focused on those, as many of you are probably aware if you work with quality and you understand HEDIS and quality measures. So here we have 2 examples related to loneliness and food insecurity, which correlate to the SDOH of social and community context and economic stability, respectively. Now pay attention to the text in red so that you can see that these are not isolated problems and they have very real costs. So ignoring them is not an option, nor is hoping that the government or some other entity will take responsibility for them. And these are just 2 examples. These are complex problems with complex solutions that affect very real people and cost very real dollars. And as you will soon see, everyone has a part in addressing them: government, payers, providers, members, and the communities in which they live. So, in keeping with our second learning objective, we're going to go back and review how states are implementing health equity and SDOH strategies into healthcare delivery for the Medicaid population. Now, we know that Medicaid serves populations with greater social needs, and so it makes sense that states would be doing quite a bit to leverage various mechanisms to address SDOH as part of their overall value based care focus. Now, the evidence base for the cost effectiveness of addressing SDOH is strongest for high need populations. For example, providing supportive housing to a seriously mental ill person who otherwise would be homeless can significantly reduce medical expenditures on emergency department visits and inpatient care. I am betting that many in this audience are familiar with the concept of quote unquote frequent flyers in the emergency department. And there are many innovative ways that health plans are moving the needle on reducing emergency department visits and inpatient care by partnering with community stakeholders. Now, for example, in my state of Virginia, I'm located in Central Virginia. Virginia Commonwealth University Health System has collaborated with the Virginia Supportive Housing to rehouse 10 patients, 5 with sickle cell disease, which can cause recurrent and expensive pain crises, and 5 who require complex care that don't have sickle cell disease, into studio apartments with site-based services. In just the first 10 months of this program, total patient cost to the hospital system dropped by 37%, largely because of reduced inpatient visits and length of stay. And that's pretty significant, pretty large evidence for the success of these innovative programs. Another example would be connecting low-income older adults with chronic conditions to the Supplemental Nutrition Assistance Program, also known as SNAP, or providing home meal delivery, and there are a number of companies that do that now, have been shown to reduce healthcare costs and utilization as well. Now, in November 2023, HHS issued this call to action with the intent of catalyzing efforts at the community level to encourage partnerships across sectors, including healthcare, social services, public and environmental health, government, and health information technology, to address social needs with the goal of improving the health and well being of every American. Their call to action describes key actions that partners in these different sectors can take to help build a stronger, more integrated, and social care system, and it provides resources applicable to partners involved in each set of actions. Now, states were granted the statutory authority to address health related social needs through a variety of authorities. And many of you may be familiar with these or even work with these at the state level, including state health plan authorities, Section 1915 waivers, managed care in lieu of services and settings, also known as ILOS, which is how I will refer to them as the acronym, and Section 1115 demonstration waivers. And again, a lot of you are probably familiar with those. CMS has a document which contains a list of HRSM services and supports as of November 2023 that are allowable under specific Medicaid and Children's Health Insurance Program authorities. All interventions must be evidence-based and medically appropriate for the population of focus based on clinical and social risk factors. Now, states have the flexibility to propose clinically focused and needs-based criteria to define the medically appropriate population subject to CMS approval. Now, generally, states have not been able to use federal Medicaid funds to pay the direct costs of non-medical services like housing and food, such as in the examples that we talked about. However, within Medicaid, states can use a range of those state plan and waiver authorities to add certain non-clinical services to the Medicaid benefit package, including case management, housing supports, employment supports, and peer support services. Historically, non-medical services have been included as part of Medicaid home and community-based services programs for people who need help with self-care or household activities as a result of their disability or chronic illness. Now, there are other requirements and limitations, including fiscal limitations in the provision of Medicaid-covered health-related social needs services as an ILOS, which are further delineated in the framework and separate guidance on provision of ILOS. So there's separate guidance for ILOS, and we're going to take a look at those on the next slide. Additionally, for Section 1115 demonstrations, these requirements include that expenditures on health-related social needs services cannot exceed 3% of the state's total computable Medicaid spending. Infrastructure costs cannot exceed 15% of total health-related social needs spending, and state spending on related social services must be maintained or increased. And that's as compared to the state spending prior to approval of the Section 1115 demonstration. This is related to CMS budget neutrality policy. Now, in its approvals of the waivers, CMS has indicated that health-related social needs spending will not require offsetting savings. Further, as a condition of approval for health-related social needs services and related infrastructure under Section 1115, states have been and will be required to ensure provider payment rates in primary care, obstetrics care, and care for mental health and substance abuse disorders meet minimum thresholds or commit to improving those payment rates. This condition of approval reflects that connections to care can only be successful if beneficiaries have timely access to care and providers. Furthermore, states must adhere to systematic monitoring and robust evaluation requirements, including performance reporting on quality and health equity measures. It is very likely that many of you are familiar with these quality reporting requirements and work with them often. Now, as of February 2024, CMS has approved Section 1115 demonstrations in 8 states that authorize evidence-based social needs services for specific high-need populations. 11 other states have approved 1115 waivers with SDOH-related provisions that predate the newer Biden administration health-related social needs framework. 6 additional states have SDOH-related 1115 waivers pending review at CMS. The waivers include monitoring and evaluation requirements through performance reporting on quality and health equity measures. It is also relevant at this time to mention that waiver priorities often shift from one presidential administration to another, so there may be changes to states' ability to pursue these initiatives in the coming years. And fortunately, we've started to see a lot of content, such as webinars and discussions, related to how this might change in the next presidential administration and beyond. Okay, so I promised you we would shift our focus slightly to Medicaid managed care, because of course this is Medicare Health Plan Association. So we're going to talk about managed care here, because we have 2/3 of Medicaid beneficiaries enrolled in risk-based managed care plans. So they are a very important part of this. So to expand opportunities for states to do this, CMS announced new flexibilities that are available to states through their managed care authority and through 1115 demonstration waivers, as we talked about previously. Some efforts may address a single issue, such as housing or food insecurity, while other efforts and initiatives are designed to address a range of SDOH. Now, under federal Medicaid managed care rules, MCOs can be given flexibility to pay for non-medical services through what is called in lieu of authority, and you have this defined up here in the first bullet. States may allow Medicaid managed care organizations, MCOs, the option to offer and provide beneficiaries the option to receive services or settings that substitute for standard Medicaid benefits. So that's the in lieu of service, or the ILOS I was talking about earlier, if the substituted service is medically appropriate and cost effective. For example, a state could authorize in-home prenatal visits for at-risk pregnant beneficiaries as an alternative to traditional office visits, or services provided by peer supports as an alternative to psychosocial rehabilitation services for members who have behavioral health needs. In January 2023, CMS released guidance that paves the way for states to allow Medicaid MCOs to offer additional services like housing and nutritional supports as substitutes for those standard benefits. Now, under federal rules, Medicaid MCOs can also pay for non-medical services as value-added services. Now, value-added services are extra services that MCOs can voluntarily provide outside of covered contract services. These cannot be built into managed care rates, however. Costs associated with value-added services are included in the numerator of the medical loss ratio calculation, either as incurred claims or quality-related activities. Examples would include safe sleeping spaces for infants, repairs and cleaning services to reduce asthma triggers, the installation of a shower grab bar, and health play and exercise programs. In a 2023 Kaiser Family Foundation survey of Medicaid directors, most managed care organization states reported leveraging Medicaid contracts, MCO contracts, to promote at least one strategy to address SDOH in fiscal year 2023. More than half of managed care organization states reported requiring those organizations to screen enrollees for SDOH, screen them for behavioral health needs, provide referrals to social services, and partner with community-based organizations, and you all probably know those as CBOs. Fewer states reported requiring MCO community reinvestment, such as directing plans to reinvest a portion of their revenue or profits into the communities they serve, compared to other strategies. Now, states can use incentive payments or quality withhold arrangements to reward plans for investments and or improvements in SDOH. For example, states may provide incentive payments to plans that screen enrollees for social needs or make other strategic investments in addressing health-related social needs, or incentive payments to improve or maintain quality while lowering costs. Remember, going back to that quintuple aim. Additionally, many plans have developed initiatives and engaged in activities to address social needs beyond the state requirements. However, it is difficult to compile national data to reflect this and understand how this is happening. Now, states can seek CMS approval to require managed care organizations to implement value-based purchasing models for provider reimbursement, such as pay per performance or bundled payments, or participate in multi-payer or Medicaid-specific delivery system reform or performance improvement initiatives. For example, a state could require managed care plans to implement alternative payment models, also known as APMs, or incentive payments to encourage providers to screen for socioeconomic risk factors. So, extending a little bit more into our policy levers, as required by law, states must establish a system to monitor performance of their managed care programs to make sure that they are reducing costs while maintaining quality or improving quality. And when ILOs are included in a managed care plans contract, they must also be part of these monitoring activities. And so states have to ensure that all ILOs are medically appropriate, cost effective, and also offered at the option of the enrollee in managed care plan. And there are six principles that are critical to the appropriate and efficient use of these ILOs, and I have listed them here. And you notice that cost effective is one of them, being medically appropriate, providing in a manner that preserves enrollee rights and protections, subject to oversight and monitoring, and respective evaluation when applicable. So those six principles are critical to the appropriate use of these ILOs. And that brings us to our next polling question, which is going to move us next into our next learning objectives, and that is asking, who is responsible for health equity strategy and execution? And you've got a number of choices here. We've got health plan CEOs and the health plan staff, the government, providers and their office staff, community organizations and resources, every single person in the US, all of the above or none of the above. And so here's a hint. So I told you what the answer was back on slide 10. But in case it is no longer top of mind, the answer is F, all of the above. Everyone has a part to play here. So all the way through the people who greet and check in members at providers' offices, all the way through the community and the government. And you will see this illustrated in the next slide. And we're going to spend quite a bit of time on the next slide. Now, it might seem that because so many have a part to play that it is impossible to visualize who is supposed to do what. But hopefully on the next slide, I've simplified it into an ecosystem approach that clearly outlines 5 key strategy considerations for providers, health plans, and the community. So without further ado, I give you the 555 Integrative Data Health Equity Ecosystem. And we're going to spend quite a bit of time here. So let's move into a discussion of our last two objectives, which are to understand how comprehensive payer and provider collaboration is critical to the success of health equity strategies, and to explore how to leverage data to gauge the social need index of a population that effectively informs strategies for care management and quality in this space. So, we are going to start. First, I'm going to start by defining just a few terms. Again, many of you may be familiar with these, but I want to make sure that anyone who's new understands what I'm talking about when I say that retrospective strategies are those that essentially look back, such as medical chart audits and the reporting that we've been talking about. And prospective strategies include those that are designed to what we want to focus on prevention and wellness. So retrospective is looking back, and prospective is money looking forward, trying to get ahead of illness and focusing on wellness. So, as I was preparing for this webinar, I wanted to present a visualization of these objectives that effectively illustrates that information sharing. So we're talking, you see here, we've got interoperability and collaboration arrows between each of these roles. And so really we're talking about information sharing here. And so I wanted to illustrate how interoperability and collaboration are what ties together each of these ecosystem roles. Now, when I say interoperability, I don't want your mind kind of going down the technical rabbit hole of FHIR interfaces and things like that, but rather down the rabbit hole of information sharing and data exchange. Now, to help my message resonate better, I tried to identify 5 quick bullets that describe at a high level the responsibilities that are most impactful for the role from a health equity perspective. So each role and its responsibilities would warrant a webinar in and of itself. But I'm hopeful that you'll come away with some actionable insights and that can guide your decision making, as well as help you understand that what you do affects others in the ecosystem through the lens of information sharing and data exchange. Now, one thing you will also notice is that I included the government as the backdrop for the ecosystem. And so you see it in very, very, very light letters behind the circle, rather than a distinct role with associated responsibilities. And the reason that I illustrated it this way is because the government's role is related to policy and guidance gained through collaboration with everyone in the ecosystem, and as a giver and receiver of information to everyone in the ecosystem. So I also want to mention that you will notice that each of these roles has a high level responsibility of advocacy. Now, I equate the concept of advocacy with the desire to ease the burden of navigating our complex health system and using our voices to communicate that desire and how to satisfy it. And by so doing, we can ensure equal and equitable access to healthcare that satisfies the requirements of the quintuple aim. So let's first take a look at providers. Now, because the member's journey, we've got the members at the center, always at the center, often starts with the provider. Providers arguably have the most important role because they capture and share the data that enables the most intelligent decision making related to specific SDOH needs by others in the ecosystem. Now that health systems and providers are increasingly taking on risk through various alternative payment models, they are more incentivized than ever to leverage insights into the ways that SDOH impact the cost of healthcare. Now, all 5 of these activities for the provider that you see on the screen are ideally EMR or EHR enabled, so electronic medical records, electronic health records enabled. Even the screening. There are many screening tools available that are approved for use by CMS, such as the PREPARE, which is the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences, say that 5 times fast, tool. This screening can be uploaded into many EMRs as structured data, and so it is a best practice to ensure that SDOH screening and capture is incorporated into clinical workflows and systems. Another example is the Health-Related Social Needs Screening Tool, also known as the AHC HRSN. It is important to use a tool that is approved by any applicable regulations and guidance. The key to this is not to make it too overly burdensome to already busy providers and to incorporate it thoughtfully into workflows. Providers are also able to use this information to make referrals for services and share information with health plans for care coordination, which also emphasizes the importance of screening and capture. In turn, health plans can also share information with providers about services that members receive or need. This type of communication has also been called social prescribing. So, any of you that do any reading about this may have seen that term used. Now, we're going to talk a little bit about coding and documentation, everybody's favorite subject. So, for all you coders and billers out there, most of you probably know that there's very specific ICD 10 diagnosis code guidance on who can capture these SDOH and health related social needs and how they should be documented in the medical record. Now, a whole webinar could be done just on SDOH coding alone, and I have done those. So, those are available, but we will hit the highlights here because they're important. These codes are generally in the code range of Z55 to Z65 and should be assigned as many times as documented by the provider during any assessments that are completed. And in summary, the coding guidelines for these codes state that ICD-10 code assignment may be based on medical record documentation from clinicians involved in the care of the patients who are not the patient's provider, since this information represents social information rather than medical diagnoses. Now, these clinicians include, but are not limited to, non-physician providers such as social workers, community health workers, case managers, nurses, or other similar providers. There are also a number of procedure codes like HCPC and CPT codes that are related to health equity related services and SDOH risk assessment. There is also specific health equity related guidance for E&M coding, since the social determinants of health screening increases the management risk and affects the medical decision making component of E&M code assignment. This also means that there could be negative payment impacts resulting from not collecting and submitting this data completely and accurately on claims. Now, for hospitals specifically, the reporting of SDOH is mandatory as of January 1st, 2024, and is required for all inpatient admissions with a deadline of May 15th, 2025. And this includes for food insecurity, interpersonal safety, and housing insecurity, with 2 optional domains of transportation insecurity and utilities. CMS has introduced 2 inpatient quality reporting measures for SDOH in 2024. And the first is screening for SDOH, and this is measuring the number of patients that were screened for the 5 domains of SDOH for 2024. And then the identification measure, and this is data mining of the patients who screened positive for any of the 5 domains of SDOH from those assessments. Now, CMS also released updates to the 2024 Inpatient Prospective Payment System, and they did this in August of 2023, and it changed homelessness from the severity designation of non-complication or comorbidity, so a non-CC, to a complication or a comorbidity. And this financially incentivizes collection of this data. Therefore, failure of hospitals to properly capture this information can also result in negative payment impacts. So, I have mentioned some claims related and payment related topics here. And so now we're going to talk a little bit more in depth about this. And don't worry, I'm not going to go super deep, but it's really important. And I'm going to tell you why. So, one of the most common challenges that I see when I take a look at what entities, are doing for organizations, whether they're providers, health plans, or anybody, one of the most common challenges that I see relates to EMR and billing systems' ability to store ICD-10 diagnosis codes and HCPC CPT codes and extract them from billing systems onto claims that are being submitted outbound to payers. So, many providers and health plans have implemented pre and post encounter clinical documentation review to ensure that all applicable codes are completely and accurately captured, so any issues can be brought to the provider's attention even before a bill drops. That is a best practice. So, if you learn nothing else from this webinar, learn that. That is a best practice. Providers should ensure that they are not using outdated super bills or charge capture templates, and be sure that any in use, whether they're electronic or on paper, are updated to facilitate capture of SDOH related diagnosis and procedure codes. Again, we're making this easier for providers. It is here where we really start to see the importance of the interoperability and data exchange to facilitate coding and documentation reviews and to be able to intelligently share information with providers and plan care managers about the SDOH needs of their members. Dedicated ongoing education that is informed by appropriate metrics will help health plans develop a clinical and non-clinical documentation improvement program that is specific to providers' needs. And so let us now turn our attention to the health plan role. And our health plans are over here on the left-hand side. So for all the reasons that we've talked about, it is very important for health plans who receive claims from providers to be able to set metrics that quantify from claims how many of these codes are being captured by providers, and to quantify from either concurrent or retrospective chart reviews the coding accuracy so that appropriate provider information sharing and education can take place. That is another best practice. You heard it here first. Even if your job has nothing to do with medical claims, billing, or processing, you should know that on the 837 electronic professional claim format, up to 12 diagnosis codes can be transmitted, and on an institutional claim, up to 25. If there are more codes than 12 or 25, there are ways to ensure that all codes are submitted to the health plan, but it does require a bit of technical expertise to enable that. Paper claims can accommodate even fewer. So, the metrics of overall code capture plus the average number of codes per provider enable the identification of trends that warrant further investigation. So, for example, if during your provider profiling exercise you see that a provider is submitting no SDOH related codes, and B, their overall number of diagnoses reported per claim is no more than 4, you can reasonably assume that they either not capturing them at all, which is a problem, or, and you can determine that easily via a retrospective chart audit, or whatever system they are using for billing doesn't have enough room to store and transmit the codes, or it is not appropriately extracting them to the outbound claims. Such a situation would warrant ensuring that provider workflows enable the code capture, the screening and the code capture, and that provider systems allow for maximum code capture and transmission on claims. You may have to get creative in how to incentivize providers to make these changes in the interest of improved code capture, which then drives better health equity and SDOH strategies. Similar to providers, many health plans have implemented retrospective clinical documentation review to ensure that all applicable codes are completely and accurately captured so that any issues can be brought to providers' attention more quickly. I've seen this, for example, successfully done with large health systems that actually sponsor health plans, and they embed people in to do this in their largest practices because the ROI is there to do so. Now, believe it or not, all of this non-clinical activity is necessary and arguably the most important for the most comprehensive approach to clinical and non-clinical documentation improvement. So now you likely can already see how the success of the health plan's ability to optimally support its members' SDOH needs is heavily dependent upon the data that the providers are submitting and information sharing through interoperability. So we're hearing interoperability and collaboration. And we've talked about provider clinical documentation improvement and set the stage for the rest of the critical health activities in the ecosystem. Let's talk about how this information sharing informs benefit design. Now, the member's experience starts with member stratification into groups based on their risks and thoughtfully designed benefits in accordance with the applicable state-specific statutes that we reviewed earlier. Input shared with other data sources such as claims, care management, and SDOH referrals that illustrates actual utilization can be compared to what was forecasted as being needing to be provided, also contributes to the optimal benefits designs for the population. This can also be compared to data sources that originate with the community at large and the government, such as community needs assessments and census data, to ensure that benefits are optimally targeted for the population. Some sources call this hot spotting. And so let's explore a good example of this hot spotting related to food insecurity. Okay, so let's say after your hot spotting activity, you decide that you're going to implement a program to target food insecurity in communities where geographic information systems and demographic data, see, lots of data, tells you there are very few fresh food sources within a certain radius of the target population. And that's actually the case in my community because I live in a very rural area. Maybe you have a food bus that visits the community and can make food drop offs, as I have in my community. Or perhaps referrals are made to community-based food pantries or a food box subscription delivery service. If you truly if you have a truly integrated data-driven health equity approach, you should be able to clearly see longitudinal evidence and claims and other utilization data of the effectiveness of these programs related to cost and quality. Remember, evidence-based is a requirement for these SDOH and health equity focused activities. Also remember that unlike many forms of acute care, where the evidence of care quality manifests fairly quickly in the outcomes, SDOH is a long game. One of the industry's biggest challenges has been how to calculate return on investment for health equity related strategies, but these strategies do not lend themselves to traditional forms of ROI measurement. That is a webinar for another day, but there are now some good scholarly papers that have recently been written on how to do that if you have interest. And there's a slide at the very end of this presentation that has several of them. After all, I am also a scholar and it's all about the peer-reviewed recent papers. And like I said, hopefully, those if that's something that you're struggling with, demonstrating to your leadership, the ROI of doing this, there are some helpful links at the end of the presentation. Now, closing the referral loop when referrals are made for these services and supports is important to being able to tie outcomes to these activities. So coming back to our food insecurity example, you not only want to be able to track how many members received a referral for food-related community-based or other services, but also how many members actually received the services and closed the referral loop. And then you'll be able to link this to outcomes and quality measurement. Because remember, these have to be evidence-based, so it's very important to do that linking. There's been some important work done by the good folks over at the NCQA on HEDIS. And as of right now, many of you likely know that there are 23 HEDIS measures that are stratified by race and ethnicity. They have also been working, folks at the NCQA, on a measurement for equity framework for Medicaid. Say that one also 5 times fast. And this can serve as an effective guide for measuring equity-related outcomes. Now, you'll need a way to exchange data with these entities to track referrals and outcomes in order to improve care coordination and quality. And this includes the ability to connect with community-based organizations that provide resources for members. And so now is an appropriate time for us to hop up and talk about up to the top of our graphic here and talk about the community. Now, because our focus today is on health plans, we won't go into too much detail about the community's responsibilities, but I do want to hit the relevant highlights. Now, key aspects of a community's SDOH responsibility include, first, identifying local needs. The most important activity, arguably, is conducting assessments to understand the specific SDOH challenges faced by different populations within the community. As an example, not-for-profit hospitals are required by law to conduct community health needs assessments as a condition of receiving their tax-favored status. So this is a good example of data that can be used across the ecosystem to enable the most positively impactful SDOH and equity-focused programs from a cost and quality perspective. And this is publicly available, so that's a good place to start if you want to know how you would start to do this. The second is community engagement. A great way to gain insight into the community's needs is involve the residents in decision making and raising awareness about issues that affect them and mobilizing them to take action. An important part of this is a concept called cultural competence. And this is, recognizing and respecting cultural diversity in the community. This is crucial because understanding the cultural norms, beliefs, and practices of the communities allow organizations to address their specific needs. For example, Some groups may not feel welcome or comfortable visiting hospitals or clinics because of language barriers or discrimination experienced at an individual community level, or because of their cultural traditions or any other issues. This discomfort by itself, or when combined with other barriers like cost or accessibility, may prevent ethnic and racial groups and non English speaking people, those who are deaf or blind, people with a disability, and others from getting the health care they need. The third is collaboration with stakeholders, and there are numerous ones, and we've talked about some of them already with providers and health plans. And similarly, partnering with local organizations, businesses, providers, schools, the government, and community leaders is very important to be able to effectively address community specific SDOH issues. For example, organizations can assist patients with their needs by utilizing or hiring community health workers, also known as CHWs. These workers are frontline health workers who have a deep understanding of the communities they serve and can be patient advocates and guides through the available community resources that are in the community. They are often representative of the populations that are served with lived experiences that help them make connections that clinical workforce might not be able to make. Next is actually providing accessible resources. And this includes supportive programs and services that address those SDOH needs. Things focused on food security, transportation, housing, assistance, job training, the list goes on. Based on needs identification and community and other stakeholder engagement, it is then necessary to provide the resources. So it's one thing to make a big plan and do the assessment, but then you actually provide the resources and promote access to them. And then last but not least, and this is one that is frequently left off, much to my surprise, but again, I work in technology, so this is kind of naturally where my brain goes, and that is enhancing data infrastructure. Now, in order to facilitate the optimal information sharing and collaboration, data infrastructure must be in place that allows efficient storage and access to data that health plans and other stakeholders across this ecosystem need to inform their equity strategies, and also doing this while managing data privacy and security, because nobody wants to be the next headline or having to send out a bunch of letters about, a breach. Data infrastructure is something that is actually pertinent to every role here. So this is not something exclusive to the community. Everybody has to be concerned about data infrastructure to house the data that they need to make this all work. Because in order to gain the best insights and intelligence from data, it has to be accessible and it has to be usable. So, if all of this seems really overwhelming to you, luckily there are a number of technology partners that can help you create a foundation for success in health equity that positively impacts cost and quality while remaining aligned with state regulations and guidance that we reviewed related to health related social needs. For example, one health plans program utilized AI enabled solutions to identify mothers at risk for preterm births, taking medical and socioeconomic factors into account to determine the best care plan. And the initial results of that program, which began in May of last year, have been largely successful. Preterm births have been reduced by 13% for the high risk group. A virtual maternity care program called Baby Scripts recently partnered with the Lyft ride sharing app to provide transportation for women who are pregnant and postpartum in Washington, D.C., where there are significantly worse maternal health outcomes than the national average, with roughly 30 out of 100,000 women dying in childbirth compared to the national average, which is 23 deaths per 100,000 births. Black women represent 90% of birth related deaths in the district, and programs like this one hold great promise for the more equitable outcomes that this population deserves. Now, these are by no means isolated examples. Organizations everywhere are starting to leverage the power of their data to develop strategies like these that positively impact cost and quality and support the achievement of the quintuple aim. So, as we bring our time together today to a close, I always like to close my presentations that are focused on this topic with this graphic. A man walking along the beach noticed a child tossing things into the ocean. Approaching the boy, he asked, "What are you doing?" The child replied, Throwing these starfish back into the water. The sun is up and the tide is going out. If I don't throw them back, they'll die. Son, the man said, there are miles of beach and hundreds of starfish. Saving a few won't matter. After listening politely, the boy picked up another starfish and smiling said, it matters to this one. And so I want to thank you before we move into our Q&A. I want to thank you for your time today, spending some time with me talking about a really important topic where we all play a part and the part that we play matters. It matters very greatly. And so if you have interest in knowing more about this topic or you'd like to reach out to me, I pride myself on being a very accessible expert. And so my information appears here. And I leave you with this quote from Owen Seymour Arthur, who was the Barbadian prime minister from 1945 to 2020. For he who has health has hope, and he who has hope has everything. And so with that, we can take a look at the chat and see if we've got any questions. Maybe Eric, you'll shout out if you see any questions here.
Sure. It looks like one of the questions we received is regarding around whether you are planning on sharing the presentation afterwards. I know you covered a ton of ground. Like I said at the top, the session is being recorded and will be on MHPA's YouTube channel. But are you planning on sharing some of this great information through another channel as well?
Yes, absolutely. I usually post things like this to my link tree, and so you have that link here. So a lot of the work I've done, um, whether it's SDOH, whether it's technology, whether it's risk adjustment, is all on my link tree. And so I definitely go there to explore what I have there as well, and a lot of it's related to SDOH. And then I'm just going to flip over to this last slide so folks can see our articles on calculating the ROI of SDOH. And you can see here that I've included many. I think the earliest publication date of these is 2018. And I have two here that are very recent that are 2024 articles. Some of these actually have really handy tools for leading folks through actually calculating this ROI, because like I said, it doesn't lend itself to more traditional ways to measure it as we know in the business world. So hopefully those links will be helpful to people. And those will be also in the slide deck that goes out.
Great. Well, I don't see any other questions that have come in at this stage. Oh,
Okay, I have, there are community-based organizations poised to offer services to address social needs, but they are currently grant funded, so capacity is limited. Do you see a future where health plans or healthcare providers have business relationships with community-based organization, maybe community care hubs to address social determinants of health? I absolutely do see this. And I see this, in fact, at Centauri, we have a couple of health plan clients who have community care hubs. They function as like community centers where not just the health plan members can come for screenings and for social interaction, for referrals to social services, but it's open to the community at large, which I think is pretty amazing because they're not just saying, hey, if you can only come to the center if you are a member of the health plan. This one of our health plans actually focuses on the Asian population, and so they also offer services that are, more Eastern medicine, like your acupunctures, gua sha, herbal medicine, things of that nature. And both of these health plans have placed these community centers very strategically. So they place them in areas where the social needs are greatest, and they have definitely seen positive impacts on health outcomes in those areas. So, and I see more of that happening, especially now since we're building an evidence base, because people are saying, we're going to do this. We believe there's a return on investment for doing so, and they're seeing that. And so I only see, more of this happening in the future. And I hope that answers your question. Thank you for asking it. Great question. And I think that's it. I don't have any more questions that have come in. Let
Yeah,
me
I
just
don't
make
think
sure. Nope, I think we're good.
I think we're good. So with that, I will thank Dawn. She covered a ton of ground today. Thank you so much for taking time and sharing your great expertise. As Dawn said, if you have questions about the presentation, like I said, I know she covered a lot. Feel free to reach out to Dawn and the Centauri team directly. You can also reach out to me. I'd be happy to connect you as well, whatever channel you think will be most effective. As I said, the presentation will be recorded, so you can find it on MHPA's YouTube channel. So with that, I will thank Dawn for her time, and I'll thank everybody else for attending today's session, and we'll close out. Have a great afternoon, everybody.
Thank you, everyone.